Welcome to the GHAPP MASLD MASH Community Network. Our topic today is on MASLD and MetALD. My name is Oyin Penny, and I'm a nurse practitioner with Premier Gastroenterology of Kansas City. Use this QR code to record your attendance for this meeting tonight. We're going to get started with our case study here. This is Ashley, who is a 52-year-old female who was referred for evaluation of abdominal ultrasound that showed mild hepatomegaly and increased hepatic echogenicity that's consistent with steatosis. She tells you that she feels fine. She does not have any GI symptoms, no abdominal pain or nausea or vomiting. Medical history includes PCOS, hypertension, and hyperlipidemia. This usually will clue you that this patient probably has some underlying metabolic disorder. Social history, she tells us that she drinks 2 glasses of wine daily on average, so it may be a little bit more on some days. On physical exam, you palpate her liver. She has a smooth, non-tender liver edge. And her medication that she's on is amlodipine, atorvastatin, multivitamin, and she's already taken milk thistle, which tells me that she probably knows she has some underlying liver disease. Her vital signs are pretty much unremarkable for the most part. She does have a BMI of 29.4, which is a little bit more on the overweight side. Her ALT is a little bit elevated at 46. AST and ALK phos are normal. Her T-billy is slightly elevated at 1.2. Platelets, 210,000, which is normal. So there's no evidence of, nothing to kind of suggest that she has decompensated liver disease. Her hemoglobin A1C is 5.9%, which is more in the pre-diabetes range. Her triglycerides are normal, a little bit elevated actually at 185. So a little bit elevated triglycerides there. So this patient gets a FibroScan. When she got a FibroScan, she has a KPA of 11.4, which is more suggestive of significant fibrosis F3 stage. Her CAP score is 310, suggestive of severe steatosis. So this slide here is actually a very helpful slide that I like to refer to. It's the slide that kind of goes over steatotic liver disease, which is the new terminology that we use now for fatty liver disease. It's this overarching term that we use to describe the different etiologies of fatty liver. And on the left there, you would see what we now call MASLD, which used to be NAFLD, metabolic dysfunction associated steatotic liver disease, MASLD. And then you have metabolic dysfunction associated steatohepatitis, which is MASH, which used to be NASH. And next to it, you have the little subset of patients that have both MASLD and they also consume alcohol. And that is what we now call MetALD. So those patients that drink, for instance, if a woman drinks 20 grams of alcohol or more, she's considered to, a day, she's considered to have MetALD. A man's allowance is about 30 grams. Anything more than that is also considered to be MetALD. And you would notice that there's a section that says MASLD predominant. Those are patients that have underlying MASLD who drinks around the daily allowance of alcohol. As they start to drink more, they're veering more towards the ALD predominant. So they have either MASLD, MetALD, MASLD predominant, or they have MetALD, ALD predominant. And then next to that, you have your alcohol-associated liver disease, which are those patients who do not have any underlying metabolic liver disease. They just drink a lot of alcohol, and that is what caused their steatosis. These patients are the ones that you would get on ultrasound that have no other metabolic issues. You see their ultrasound shows fatty liver. It's not because they have MASH, it's because they just drink a lot of alcohol. And next to that is a specific etiology, steatotic liver disease. These patients could be due to drug-induced liver injury, DILI, and that could be from, for instance, a patient that has breast cancer and has been on tamoxifen and they develop fatty liver as a result. And then you have those patients that have monogenic diseases that could be, for instance, as a result of Wilson's disease. And then you have miscellaneous causes. For instance, HIV would be an example, which can also cause fatty liver. And then on the far right are the cryptogenic SLD, which we do not know why these patients actually develop steatotic liver disease, but they have it. So this is kind of a helpful slide here in determining what the alcohol content is in the different types of beverages, alcoholic beverages that people drink. For instance, a 12-ounce fluid ounce of regular beer has about 5% of alcohol in it. A 5-ounce of table wine has 12% of alcohol in it, and a 1.5 fluid ounce of shot of your 80 proof distilled spirit has 40% alcohol in it. And this is quite helpful to have as a reference. And when you're asking your patient about their what they're drinking, if they're drinking, it's also important to ask them what they're drinking. I've actually had a patient that I've asked them about their alcohol intake. They basically told me they do not drink alcohol. And they later on told me they drink beer. They didn't consider regular beer alcohol. So sometimes we have to like really dig in to get those information out of our patients. So the key pathogenic mechanism in dual etiology, we know that steatohepatitis is due to inflammatory response. And NAFLD, the risk factors are usually some of the causes of fatty liver, fat in the liver steatosis. So insulin resistance, diabetes, obesity, visceral fat are some of the reasons why patients develop fatty liver. There are also environmental causes. And then alcohol is also another reason why they can develop fat in the liver as a result of impaired lipid handling. So then this goes through under oxidative stress, causes cell injury, and then cell death. And then kind of leads to this whole inflammatory cascade. And then that can also accelerate the fibrosis and disease progression of the liver. NAFLD and alcohol also is known to disrupt the intestinal microbiome. So that in itself can also set off an inflammatory response, which accelerate fibrosis and disease progression, which is why alcohol actually has a synergistic effect when it comes to MASLD and alcohol use. So those patients that drink a lot of alcohol, or even if it's moderate amount of alcohol, and they have underlying fatty liver disease, can progress to fibrosis and then ultimately cirrhosis of the liver. So this slide goes over the drivers of liver disease. We know that the main disease drivers are cardiometabolic risk factors. We kind of went over that in the previous slides. Obesity, insulin resistance, type 2 diabetes, dyslipidemia, etc. And then we have the genetic risk. For instance, if a person possesses the PNPLA3 gene or the MBDOA-T7 gene, these patients for some reason have a higher risk of developing fatty liver or steatohepatitis that progresses pretty quickly. And that would explain why you would see some patients that are like in their early 30s that have steatohepatitis, and they, over a short period of time, have developed advanced liver disease. And then we know, of course, that alcohol also causes fatty liver to progress, as mentioned earlier. If you look at that table on the very top, that gives you the risk estimates for decompensation in your patients with fatty liver of any kind. So for instance, if your patient has MASLD, their 5-year risk for decompensation, if they have F3 or F4 fibrosis, is actually about 5 to 15%. If they have MetALD, meaning they have underlying MASLD and they drink alcohol, their 5-year risk is 10 to 30% if they are stage 3 to stage 4. And then ALD, just predominant, that's all alcoholic liver disease. Their 5-year risk is actually higher than that at 15 to 50%. So that tells you right there that alcohol definitely plays a huge role in the compensation of liver disease. So when it comes to fatty liver, we know that alcohol can cause fatty liver. We know that metabolic issues cause fatty liver, whether it's genetic, whether it's metabolic, right? So patient has steatosis. Not everyone that has steatosis will develop steatohepatitis. A small percentage of them will. And those percentage of patients, if we do not mitigate the process or halt whatever is causing the underlying inflammation or liver disease, they will eventually progress to cirrhosis of the liver. There are some tools that we can utilize when it comes to getting objective data or information on our patients' alcohol consumption. There are questionnaires out there. There are urine tests that could be used. There are blood tests that we can use. An audit tool, AUDITC tool, is a tool that can help us determine if our patient has dangerous drinking patterns or they use alcohol excessively. Blood tests such as MCV. So for instance, you get your patient's lab and you don't have a full liver workup on them yet. Sometimes you can tell if they've been drinking alcohol if their MCV is higher than normal. I will say though that it can be high if someone has folate deficiency, so it's not very specific to alcohol, but most of the time from the patients that we see, we notice that there's some correlation between their alcohol use and then their MCV being elevated. GGT is another test that someone can take. And then there's the CDT, which is a carbohydrate deficient transferrin, which actually can help detect the use of heavy alcohol in about 1 to 2 weeks. And it gives, but the patient has to really be drinking heavy amount of alcohol. It's about 50 to 80 grams a day. And then there's this calculation called the ANI, which is an alcohol liver disease and non-alcoholic liver disease index, which helps distinguish alcoholic liver disease from non-alcoholic fatty liver. So that's another tool that could be used. This tool, urine ethyl glucuronide, is highly sensitive. This actually is a urine test. It would detect alcohol in sanitizers or mouthwash in 24 to 80 hours of ingestion. And then there's also a test that does the same thing, but it uses the patient's hair, and that would detect alcohol in up to 1 month. These tests can be used in patients that drink moderate to excessive amount of alcohol, and they have their area under curve is actually pretty decent when it comes to the test that uses the hair. The audit tool is actually a little bit on the lower side. So gaps in the assessment of MetALD is like, how do we distinguish patients that have MASLD from MetALD? We've kind of gone over that already, but there's a slide that I think is helpful to kind of keep for reference. And if your patient has metabolic issues, such as type 2 diabetes or prediabetes, they're overweight, high blood pressure, isolated triglycerides, or hypertension, you want to make sure that you rule out alcohol if you're trying to determine if they have MetALD. And you can do that simply by checking a phosphatidylethanol test, which is also known as a PEth test. A PEth test would help determine if this patient has MetALD, or this patient basically has MASLD, or if they have alcoholic liver disease. If your patient has MetALD, these patients would, for instance, a female drinking 140 to 350 grams of alcohol a week will probably have a PEth level between 25 and 200, and a male will be anywhere from 210 to 420 grams in 1 week. And if they have underlying metabolic issues, it will be considered to be in the MetALD category. If they do not, as mentioned previously, if they drink anywhere from 350 grams per week for a female, and then more than 420 grams per week for a male, with a PEth level of greater than 200, then that person's considered to have alcoholic-associated liver disease. So we're going to continue our workup here with our case study. So remember, she told us she only drinks 2 glasses of wine, average a day. So she gets a PEth done, and her PEth came back 120. So she's actually more on a moderate to heavy alcohol consumption. So let's talk a little bit about phosphatidylethanol PEth test. This is a test that's very helpful because it can actually detect alcohol for 3 to 12 days after one single binge. So that means that your patient does not necessarily have to drink alcohol on a regular basis or daily basis for this test to be useful to help someone detect alcohol. The blood alcohol, you can see that it spikes in 2 hours. Like if a patient comes in, for instance, for those of us that work in the emergency department, you get a patient that comes in, we suspect alcohol. We check a blood alcohol level on them, right? Most of the time, their blood alcohol level is very low, unless they have been drinking a lot or drank literally hours before they came into the emergency department, which sometimes they do. Then you would get a level on there. But if your patient that you're not sure, they're not drinking on a daily basis, but you're not thinking, you suspect that they're not forthcoming with their alcohol intake, then you can go ahead and get a PEth level and get a more accurate information. So there's no significant variability by sex or BMI when it comes to the PEth level. So there was a study that was done with 659 patients that were screened for a study. I think 659 were screened, 42 were excluded for whatever reason. Some had Hep B, some had Hep C, some just didn't meet the criteria for age or whatever. And then 617 ended up enrolling. Then they found out that out of the 617 that enrolled, 254 either were never drinkers or they missed some information, so they were excluded out of the study. So they had like 333 left. And out of that 333, they found out that 236 of these patients actually did not meet the alcohol consumption criteria for the study. So they ended up with a total of 97 patients. So when they finally analyzed the results, they found out that 15.7% of these patients were at risk of MetALD. So that's actually a significant number of patients. So that just kind of tells you that maybe we should be doing some more better screening when it comes to our patients with fatty liver. So back to Ashley, her medical history is PCOS, hypertension, and hyperlipidemia. Those are highlighted there for a reason, and we'll go over that here shortly. So there was a 32 randomized controlled trial that was done with 767 participants, and they found out that alcohol actually has a biphasic effect on blood pressure. They did studies after a patient had consumed alcohol about 6 hours. They go in anywhere less than 6 hours, they check their blood pressure, they have low blood pressure. They check it again and repeated it 13 hours or more later and found out that their blood pressure actually increased higher than baseline. So blood pressure elevation, when it comes to patients with that consumes alcohol on a regular basis, you want to kind of determine if this is all related to their alcohol consumption, or is this partly related to some true underlying metabolic disease. Alcohol also, most of us know that affects triglycerides because it causes elevation of triglycerides. And the mean plasma triglyceride concentration was measured over 10 hours when they took patients that drank just water and 2 standard drinks of alcohol, and noticed how their triglycerides peaked around 2 hours is when it started to peak up to 10 hours there. So back to our case study, I'm just gonna review this slide here a little bit. Ashley, 52-year-old with steatohepatitis on ultrasound. She drinks 2 glasses of wine a day is what she said, but her PEth came back 120, so a little bit moderate to maybe more severe alcohol use. Her LFTs are pretty much unremarkable, except for a little bit elevated ALT of 52 T-Billy 1.2, and she has prediabetes, and her triglycerides are a little bit high, 185. She had a FibroScan done with a FibroScan F3 fibrosis and CAP score of 310. On exam, her liver edge was smooth, mildly elevated liver, and she's already on amlodipine and atorvastatin, multivitamin, and milk thistle. So we diagnosed her with MASLD predominant MetALD because of her underlying metabolic disorder, and then the fact that she drinks alcohol, and she falls into that MetALD predominant category. So the questions to answer is, this is a 52-year-old lady who has F3 fibrosis, who also has prediabetes. What are the current treatment recommendations? It's still pretty much, a lot of it has to do with lifestyle modification, right? She still needs to lose weight. Losing as little as 3% of your total body weight will make a significant difference in the steatosis, because it will decrease steatosis, and then hopefully can drive down any inflammation. And then diet, Mediterranean diet is still the recommended diet for a person that has hepatic steatosis. And then exercise is always recommended. And, it's always important to teach your patient to start low, but be consistent, to avoid jumping into this too fast, because what happens a lot of times is that they start real fast and then they overdo it with the exercise and then get discouraged. So consistency is usually the key. So is this patient a candidate for resmetirom? She should be considered for resmetirom. However, she needs to stop drinking alcohol. We know that alcohol has a synergistic effect and makes fibrosis worse, but alcohol can also buffer the effect of the drug. So in order to really get the full efficacy of the drug, it is recommended that the patient stop drinking alcohol. So those are patients that you want to counsel on abstinence. And does she need HCC screening? Yes, she does need to get HCC screening because she has F3, she has advanced fibrosis. So what is the ideal MetALD definition for clinical trials? We have already discussed why MetALD and MASLD, it's important to be able to distinguish between the two. Based on objective biomarkers, it's always important to overcome any underreport of alcohol use. We need to standardize the assessment of recent alcohol use and certify alcohol abstinence. So make sure your patient's truly not drinking alcohol. Make sure we find ways to get more objective and accurate information to overcome any underreporting of their alcohol use, and have a standardized way of checking on your recent alcohol use on your patients. Ensure that the drivers of liver disease are present. So make sure that your patient has more than one cardiometabolic risk factors. And it's also important to make sure that these risk factors are not driven by alcohol use. So you want to ensure that these hypertension or hyperlipidemia still persist after the patient has stopped drinking alcohol, if you're going to use them in clinical trials. And consider exposure to risk factors and fulfillment of criteria during the last 6 to 12 months. So here are the take-home messages. The new definition for MetALD is alcohol intake beyond 140 to 350 grams per week for a woman and 210 to 420 grams per week for a man. Clinical trial could underestimate MetALD and also ALD. So it's important to use biomarkers of alcohol such as phosphatidylethanol, PEth, and ensure that the drivers of liver disease are present. So make sure you're reassessing these patients of metabolic dysfunction over time, and consider adequate exposure to risk factors. And finally, criteria for clinical trials should facilitate an objective MetALD diagnosis and allow comparison among different social cultural realities. And that is the end of this presentation. Please visit the GHAPP MASLD and MASH Community Network for additional disease state education and Resdifra webcast. Thank you all so much for your attention. Please scan this QR code to complete a short survey and share your thoughts on today's presentation, because your insights help us continue to improve. Thank you so much.